So the next question is, what role should primary care play in Lyme disease? Well, I think critically, we need to get primary care involved as they are in the coalface in making an early diagnosis. Separate to the GPs, there needs to be Lyme awareness, obviously, in patients so that they avoid getting a tick bite. But I think critically, there has to be a raised awareness in GPs. I see time and time again patients coming in with rashes following a tick bite, and these rashes are diagnosed as fungal infections, as tinea, as cellulitis, and patients are put on topical creams or no antibiotics at all. Why does this happen? I think it's because GPs do not have adequate training. When I first came to Ireland, I started doing STI foundation courses, training courses for GPs. GPs never get training on sexual health. So I get referred in GPs all the time, patients with hair follicles that they thought were warts, molluscum contagiosum they thought were warts, styes, zits that were warts because they happened to be in the genitals. But the reality is the GPs were never given training. Over the years, we've trained GPs. We now have STI training as part of GP trainees. They come to my clinic, and I think we're in a different place now. So it really is important that GPs who are on the front line have an understanding of very basic infections, because GPs are the first line of contact for most of these infections. So I think GPs need to be involved in early diagnosis. They need to understand the kinetics of the antibody test. They have to understand that you can have an infection even if you have a negative test. They have to understand that the rash is not always the classic bullseye rash. If the rash is on your ear, it may be what's called a lymphocytoma. If it's on your scalp, you may not recognize it at all. It's sometimes hemorrhagic, it's sometimes elliptical, and a classic case that I have in my own hospital a year ago was one of my junior consultants that I trained saw a patient in the emergency room, and he had aches and pains all over, and he had this huge big rash on his back. And he was seen by the infectious disease consultants and one of my junior SBRs, and was basically, this patient was told it couldn't be Lyme because the rash was too big, and he didn't remember a tick. So he was sent out and referred to the dermatologist and referred to also a rheumatologist, who are both colleagues of mine. And 3 days later, they both sent him back to the emergency room saying, duh, this is Lyme. I get a call from the emergency room acute medical unit consultant, who's a colleague of mine. She says, Jack, we're in a pickle here. Your colleague says this isn't Lyme, but the rheumatologist and the dermatologist say it is. The rash was too big. They said you never saw the tick. Well, most people don't check their backs for ticks. He just happened to notice the rash when he was in the shower, but he had aches and pains all over. So I told my colleague to start him on a course of doxycycline, do a blood test, and the fellow came back to see me 4 weeks later, and voila, all of the rash was gone, his arthritis was gone, and of note, his antibody test was positive. So I think even the best of situations, which I would think a university hospital with an infectious disease specialist, there's not a huge training on Lyme disease, or sometimes even a willingness to learn about Lyme disease. So I think GPs need to take on ownership of Lyme disease, and because especially in areas like Scotland, I think it's much more common. But then again, all over the United Kingdom, people are being exposed to ticks. People are traveling. You don't have to live in the Northern Highlands to get bitten by a Highland tick. You can be a foreigner coming to Ireland, to Scotland. People travel all over the world, as I've said before. So an early diagnosis is critical. An early diagnosis means early initiation of therapy before dissemination has occurred, before these bacteria have disseminated and The belief is these bacteria set up shop deep in the tissues, and then at that stage it's very difficult for the current antibiotics to eradicate these bacteria. So I think it's important to come up with a quick diagnosis whenever positive, have a high degree suspicion. If you have a rash, even without symptoms, and you suspect Lyme, you should treat with the standard of care, which the NICE guidelines say 3 weeks of doxycycline. And if patients aren't better after 3 weeks of doxycycline, then repeat 3 weeks more of treatment with either a repeat of doxycycline, which is 100 milligrams twice a day, or the second course should be with amoxicillin a gram 3 times a day for a period of 3 weeks. But even today, and even in recent days, I've seen patients who suspected Lyme, went to their doctor, had a rash, had pulled a tick bite off, and the GP prescribes doxycycline 200 milligrams once a day. This is a recent experience just in the last few weeks. So we're not getting the education out there. Specialists and governments are not educating GPs on appropriate diagnosis and appropriate testing. In terms of late Lyme, I think GPs are the first who are going to be seeing these individuals. It's a little more challenging in terms of treatment, but we need to have specialist centers, and we need to have infectious disease specialists and other specialists who are open to the idea of chronic persistent Lyme. So this is really a challenge. Does Lyme persist for years and years? Absolutely it does. And I see patients who had a rash, classic Lyme rash, flu-like illness, symptoms following that consistent with Lyme, who were denied treatment because the antibody tests were negative, and I see them years later. And this is chronic persistent Lyme. And I think the GPs are going to be the ones who see these patients first off. What do you do with them? I would do a Lyme test. But even if the Lyme test was negative, I'd still have a high degree suspicion that this could be Lyme. We've done studies looking at the number of patients, the patients with chronic persistent Lyme, the number of specialists that they've gone to see, and it's quite astounding. They see rheumatologists, they see neurologists, they see endocrinologists, they see cardiologists, they see pain specialists, and eventually they see psychiatrists because nobody can figure their illness out. And sometimes Lyme does cause brain inflammation, and patients have a lot of neuropsychiatric problems. And I think after a previously healthy patient has been sick for a year and has gone to see 10 specialists, I think it does affect them psychiatrically as well. So I think it really is a challenge. It's a poorly understood infection, and I think my approach when I see a patient with a mystery illness, with migratory arthritis, where I have a suspicion of Lyme and all the tests are normal. If the tests are normal, don't say all your tests are normal, there's nothing wrong with you. I prefer to say to them, you were previously healthy, never saw a doctor for the first 40 years of your life. You've now seen 10 doctors in the last year. We've not come up with anything. We must be missing something. Patients are much more understanding and supported when you admit that we don't have all the answers in medicine, and we should work with patients to help them through these mystery illnesses, some of which are tick-borne infections.